Hello. Fluid and electrolyte therapy in a surgical patient. Fluid and electrolyte homeostasis is an essential requirement for optimal cellular and organ function. Fluid and electrolyte changes occur in the preoperative, intraoperative, and postoperative patients, as well as patients involved in trauma and those with sepsis. Hence, adequate knowledge is paramount in the management and for better outcome of a surgical patient. The total body water. Total body water forms 60% of body weight in males and 50% of body weight in females. The distribution is largely influenced by age, sex, and body fat. The total body water is higher per kilogram body weight in children, lower in elderly. It is more in males due to higher muscle mass and lower in females due to higher body fat. The fluid compartments. Total body water is divided into two compartments. The intracellular compartment, which makes up 40% of body weight, extracellular compartment, which makes up 20% of body weight. The extracellular is further divided into the intravascular, which is 5% of the body weight, the extravascular, which is 15%, interstitial 14%, and the transcellular, which makes up 1% of the body weight. Fluid balance. The fluid intake is from two sources: the exogenous, taken orally or parenterally; the endogenous, which is water release as a product of metabolism. The main principles of fluid and electrolyte therapy in surgical patients are the correction of deficits, provision of maintenance fluid, the replacement of ongoing loss, and monitoring of the patient. When a patient suffers fluid loss from vomiting, diarrhea, third space loss, or via intracutaneous fistula, they develop deficits in the form of dehydration. Dehydration is the loss of fluid and electrolyte, especially sodium. The dehydration could either be acute or chronic. In acute dehydration, there is sudden loss from the extracellular fluid, while in chronic dehydration, there is both ECF and ICF loss. Patients with dehydration present with dry inelastic skin with loss of skin turgor, dry mouth, tastes, collapsed veins, tachycardia. They may also have hypotension and slightly concentrated urine. For the correction of dehydration, intravenous access is secured. IV fluid, crystalloid, either Ringer's lactate or normal saline, is administered. The amount of fluid given depends on the extent of dehydration. For mild dehydration, where there is loss of less than 5% of body weight, this can be corrected with oral rehydration solution for patients that can take orally. Correction of moderate or severe dehydration requires passage of urethral catheter to monitor the urine output. In moderate dehydration, fluid up to 5 to 10% of body weight is lost before it develops. In correcting moderate dehydration, it is paramount to administer crystalloid until patient is making adequate urine of 0.5 to 1 ml per kg per hour in adults, or 1 to 2 ml per kg per hour in children. Fluid is administered at a rate of 20 ml per kg in 1 to 2 hours. For severe dehydration, here the fluid loss is more than 10% of body weight with associated cardiovascular compromise. Hence, it requires a more rapid correction. Crystalloid normal saline or Ringer's lactate is administered 20 to 30 ml per kg in 30 minutes or 1 liter over 30 minutes in adults. During rehydration, in severe dehydration, frequent reassessment is done to determine the response to treatment. The parameters checked are capillary refill should be less than 3 seconds. The pulse rate should be less than 100 beats per minute. The blood pressure should be more than 90 over 60 millimeters of mercury. The central venous pressure 10 to 15 millimeters of mercury, and urine output 0.5 to 1 ml per kg per hour or 1 to 2 ml per kg per hour in children, and the mental status should also be assessed. If the parameters are deranged, fluid bolus is repeated to a maximum of 4 times with careful assessment to prevent fluid overload. Otherwise, a septic, anaphylactic or cardiac shock may be considered and treated appropriately. Provision of maintenance fluid is measured by the amount of fluid loss in the urine, insensible loss via breathing or from the skin, as well as fluid loss in the stool. Losses in the tropics are estimated as follows. The insensible loss is 1,700 ml. The urine loss is 1,500 ml. In feces is 200 ml, making a total of 3,400 ml. Gain, endogenous production from product of metabolism is 200 ml. Hence, the net fluid is 3,200 ml. A surgical patient usually does not take oral, is on parenteral, and is not likely to pass 2. Hence, the 24-hour requirement is 3,000 ml. And it should be noted, for 1 degree rise in temperature, 12% of daily requirement is added to compensate water loss in sweating. Regarding ongoing loss, ongoing gastrointestinal losses such as NG tube drainage, drainage from enterocutaneous fistula, diarrhea, vomiting are estimated and added to the maintenance to make up for the fluid